Thanks, Philippa. Hi, everyone. Thanks for having me. Yeah, my name is Tom Pollak. I am a clinical lecturer at King's College London. I'm also an honorary consultant neuropsychiatrist working in South London, where I run an autoimmune encephalitis clinic. This is alongside a neurologist, Dr. Esther Coutinho. And one of the things I've been interested in for a long time is the mental health of people after the acute episode of encephalitis has finished. So I'm going to be talking about that. It's an area that there's not been that much research done in. And I'm particularly going to focus today on presenting the results of a big online survey that we recently ran, which we think is probably the largest of its kind. Just by way of a content warning, partly just by way of the nature of the kind of subject matter we're talking about, we are going to be discussing things like mental illness, suffering, suicide, drug abuse, and carer burden. So just please be aware of that. So I guess before we start, one of the questions that I get often asked as a psychiatrist with an interest in encephalitis is, well, why am I seeing a psychiatrist? This is a problem with my brain. I'm not mentally ill. And there's sort of a number of different answers to that. One answer is, well, I'm a neuropsychiatrist, and actually we do see people with brain disorders, but that's not really the best answer. I think the best answer, and this was told to me by a sort of professor of neurology 10 or 15 years ago, is, well, the mind and the brain both live in the same box. They're really the same thing. And if encephalitis damages the brain to the extent that we know it can, it's almost no surprise that it is going to result in mental symptoms and sometimes the symptoms of mental illness. And just because these symptoms can't be seen on a brain scan, it doesn't make them any less real. So I think we need to dispense with this idea that neurologists are brain doctors and psychiatrists are mind doctors, because we're really both dealing with the same thing, although perhaps we have a slightly different approach. And let's not forget that a quarter of us will experience mental illness at some point in our lifetimes. And of course, encephalitis doesn't discriminate, so it's equally likely to affect someone who has some experience of mental illness or even a predisposition towards mental illness as it is to affect someone who has no such experience. And we often hear that encephalitis is a hidden disability. Well, I think the level to which that is hidden and sort of goes one step even further when we think about the sort of the mental symptoms and the mental health symptoms of encephalitis, because they are so hidden, you can even hide them behind the smiley face. So what kind of symptoms are we talking about? Well, broadly, we could talk about problems with emotions, problems with behavior, problems with thinking. To get a bit more technical, we call these cognitive symptoms. So difficulties with language, with expression of language, with memory, with things like planning. Mood, so people can have low mood, depression, high mood. They can have sort of manic or hypomanic episodes. Their mood can jump around or be very labile. People can develop apathy where their motivation has gone. Anxiety, well, I think people are familiar with sort of generalized anxiety, but there are also things like sort of phobias or post-traumatic stress syndrome symptoms, or obsessions and compulsions. These are all things that we see. And psychosis, this is something that we're often very interested in the acute phases of encephalitis, where people frequently can develop a psychotic illness. But sometimes we see it in the sort of the later stages as well. And by this, I mean, when people lose touch with reality, when they have hallucinations, when they have delusions, or maybe they become paranoid. But remember that these are symptoms, they are not diagnoses. And what I mean by that is, just because you're experiencing low mood, that doesn't mean that you have a major depressive disorder. Because you're experiencing hallucinations, that doesn't mean you have a psychotic disorder like schizophrenia. So we have to be a bit careful that we're not necessarily labeling people with these lifelong diagnoses. And stigma is a really important thing here. You know, psychiatrists, and we spend a long time trying to fight against stigma, but it's so prevalent. And, you know, it's very difficult to talk about one's own sort of mental health issues in some sort of cultural context. It's even more difficult, you know, let alone talking about things out loud in front of people you don't know. Sometimes even talking to one's own family members is very difficult. I think these are barriers that we need to get over. The kind of psychiatric disorders that we see, well, there's actually not that much high quality research done. There are bits and pieces here and there, and Yasmin Abdat, who's a master's student from our clinical neuropsychiatry masters, has done a really wonderful job in what we call a systematic review and meta-analysis of all the kind of studies that have been done to date on the mental health outcomes in encephalitis. And there are lots of different possible outcomes, and I'll list them here, but the take-home point really is that of all the studies, they tend to focus on maybe one or two different kinds of encephalitis and maybe one or two of these kind of outcomes. there is yet to be a sort of really broad kind of approach where you're looking at all the different kinds of encephalitis and all the different kinds of outcomes. It depends whether the research is interested in anxiety or psychosis or what have you. So in terms of the disorders that we see anxiety disorders like I described, these mood disorders, post-traumatic stress disorder, and frequently that takes the form of something similar to post-ITU syndrome. People have been in the intensive care unit and often experience very distressing flashbacks and memories and behaviors around that. Psychotic disorders do occur, suicide does occur, and we will speak a little bit about that. Personality change is very difficult to kind of get a handle on. Often people receive this diagnosis of organic personality disorder, which involves sort of disinhibition and acting strangely and some degree of impulsivity. Or frank impulse control disorders, where people will gamble excessively or engage in sexual behavior or overeating excessively. And then finally, this interesting category of functional neurological disorder, where people have what look like neurological symptoms, but there's no clear structural cause for that. And I personally like to think of this as a neurological disorder as well as a sort of psychiatric disorder, but often people do lump it in the sort of mental health sphere. Lability is, so mood lability is when one's mood changes on a sort of very short time scale. So 1 minute someone's happy, the next minute they're crying, the next minute they're back to being a bit happy. But it's really a kind of second to second, minute to minute time scale rather than days or weeks. And of course, these things are likely due to many mixed causes. There are factors from before the encephalitis. Like I said, people are just as likely to have had an episode of mental illness or be predisposed to that. Encephalitis doesn't discriminate. There's the actual damage that the encephalitis itself does to the brain, to the neurons, to the neurotransmitters, which we think may persist over time. There's the psychological impact of the illness experience. It's obviously a very distressing thing to be admitted to hospital, to go to ITU, to be separated from your friends and family, particularly in the current kind of climate. And there's a quality of psychosocial support. It should be obvious that someone who's got a really good support network is likely to have a different patient journey from someone who is perhaps socially isolated and financially less able. And that's where people like the Encephalitis Society come in, by really being able to provide support to the people that need it most. Misdiagnosis is something that I often get asked about, and it's something that I think we touched on with the medico-legal talk just now, and it's a real problem in encephalitis. And it's not just psychiatric misdiagnosis, there's misdiagnosis of physical health problems as well. It's most common in NMDA receptor encephalitis. In the early days, up to 80% of patients who are first seen by mental health services. We think that's improving nowadays. And often they receive diagnoses like schizophrenia, bipolar, schizoaffective disorder, first episode psychosis, a bit like Susanna Cahalan, who's being represented here in the film of Brain on Fire, which I'm sure most people are familiar with. Occasionally other diagnoses, things like functional neurological disorder, when in fact these do turn out to be genuine epileptic seizures, or even they receive diagnosis of dissociative seizures, perhaps. We think this is occurring slightly less because of better awareness, but it doesn't just occur with NMDA, it can occur with other types of autoimmune encephalitis. In fact, it can occur with all types of encephalitis. But just because psychiatry is involved in your care, it doesn't mean that you've been misdiagnosed. Now, so occasionally this is a bit of a misconception, because there is a role for the psychiatrist in the management of any patient with encephalitis, and because these are real mental health symptoms, whether or not you have a neurological diagnosis, and often the psychiatrist is the best person to treat them. So after encephalitis, an awful lot can happen, and I'd lose my job if I didn't mention this book, which is by Ava, about life after encephalitis, which is a really wonderful deep dive into the stories of people after they've had an encephalitis diagnosis. And it goes into the kind of detail that unfortunately we as doctors are rarely able to go into, and it really brings alive some of the stories, and it's been very eye-opening to me. But to get back to the facts and figures, which doctors like so much, I say that not that much research has been done. This is a study by Julia Granerud from 2017. It uses a data set from a lot earlier, and it's looking, using GP-based records in the UK, at the rates of new psychiatric diagnoses in people who've had encephalitis. And you can see that new onset psychiatric diagnoses, including anxiety disorders, depressive disorders, psychotic disorders, are all more common, not just in the first year following encephalitis, but up to 5 years following the initial episode. So in sort of the kind of medical speak, encephalitis is a risk factor for the development of all kinds of psychiatric diagnoses. So which brings us on to our online survey. And I should add that this was really sort of run and developed by Yasmin Abdat, who's sitting here. He's going to wave right now. There she is. she's going to hate me, who unfortunately didn't supply a picture, but Matt Butler, who's a trainee psychiatrist, joined later and has also been providing some really useful input. It's a web-based questionnaire that ran from November 21 to February 22. It was developed a long time before COVID, but for obvious reasons, doing a study of mental health symptoms during COVID was not scientifically the best idea, because if you asked, are you spending excessive time washing your hands or something like that, it wouldn't necessarily be indicative of OCD. It was open to all localities around the world, all kinds of encephalitis. Patients had to be 18 years and over, but carers could complete it on their behalf. And just to say, anyone who's here or anyone who's online who did complete it, we really are so very grateful. And hopefully we can show you some of this data now, although believe me, there's a lot more analysis that we need to do. So this is just a bit of a kind of first look, bird's eye look. So hopefully it's the largest study of its kind and the only one that's looked at all kinds of encephalitis and a genuinely wide range of mental health symptoms, including some new sort of symptoms that I don't think have ever been asked about before. So in terms of who answered, we had just over 400 responses, and you can see there's a really nice geographical spread. UK and the USA, unsurprisingly, kind of in the lead, but we have answers from as far away as Australia, Indonesia, India. Pretty satisfying spread, I think. In terms of the age of people who responded, follows almost what you would call a normal distribution, with a sort of average age of around 50 years old. But we also see a sort of little peak sort of towards the younger end of the spectrum, which we think might be representing a sort of autoimmune subgroup, but we haven't done all those sub-analyses yet. I should add now, we've got lots of data on the different kinds of encephalitis, but what you won't see today are the kind of symptoms broken down according to the different kinds of encephalitis. That's something we are going to do. So in terms of the kind of encephalitis that people were diagnosed with, about 70% responded, they're diagnosed with infectious encephalitis, and autoimmune for about the other 30%. There was a few patients who had either other or don't know. In terms of the infectious encephalitis, the most common etiology, the most common pathogen was herpes simplex virus, but again, most people will sort of recognize these other causes of encephalitis, and again, a reasonable number of unknowns as well. In terms of autoimmune encephalitis, NMDA receptor encephalitis is the most common represented one here at around 32%. And then we have ADEM, LGI1, which you just heard about from Dr. Binks. Hashimoto's encephalopathy is represented here, and that's sometimes a slightly controversial diagnosis. And again, a number of others. And we're going to be looking at exactly what those others are, because I think some of them will be more or less controversial than others. So we asked, when your encephalitis first started, were you admitted to hospital? I hope you can see this. I'm sure the people online can. I hope we're all right here. But you can see essentially nearly 90% of people were admitted to hospital. The majority were admitted to a general ward. And we're a little bit surprised to see that a pretty small number, less than 10%, were admitted to a psychiatric ward initially. And I guess that's quite a positive thing, right? I was expecting it to be a little bit more than that. Although only 5% initially admitted to a neurology ward, because of course that tends to happen after some period of time. Zooming to the current day, we asked whether people are currently under the care of a psychiatrist or community mental health team. And again, we were slightly surprised to see that this was a reasonably large number of people. It was about a quarter of all patients. So things sort of looked all right and looked really relatively positive. We also asked, since your encephalitis diagnosis, have you seen a psychotherapist or a psychologist for talking therapy to address any of the mental health problems? And about half had. But then we asked, do you feel that you've had access to appropriate healthcare for your mental health and well-being? And whereas about 30% said yes, a similar number said yes, but it could be better. And about a quarter of respondents felt that they hadn't had access to appropriate healthcare for their mental health and well-being. So we're starting to get the picture that maybe the services that are provided aren't quite adequate. In terms of care and carers, we asked respondents whether they're reliant on a carer to complete their daily activities. And around 70% of respondents were totally independent. And then around 10% relied on a carer for most or all of their daily activities. And then another sort of 25% relying on a carer for some of their daily activities. So a reasonable spread. And I'm not sure, perhaps Ava could say quite how representative this is, but it feels like it's probably representative. And then this is a question that we were really interested in because we hear so much about it in clinic and from talking to patients and their carers. But it turns out that around 70% of respondents felt that caring had a negative impact overall on the mental health of the carers themselves. And again, unsurprising, but nice to have a sort of number and realize that it really is a problem. And I think hopefully having it that clearly stated will be useful. But 16% thought it had an overall positive impact, which is interesting and I suppose, you know, lucky and fortunate for those people. It'd be interesting to hear what the factors are that might contribute towards that. We were interested in sort of self-medication. We've got a lot of questions about medications. This is the one that I'm going to present to you today. It's have you ever used any street drugs to help manage your post-encephalitis symptoms? Not that many did. 8% did, and the majority who had tried cannabis, although 4 tried magic mushrooms to help deal with their symptoms. So I would love to hear what the results of those kind of experiments were.
We're not recommending.
We're not. Yeah, I should add as a disclaimer, we're not recommending it. This is not the official view of the Encephalitis Society. We then asked. We came back to this question of misdiagnosis, and we said, do you feel that you were given an incorrect diagnosis before you received the correct diagnosis of encephalitis? I'm aware the numbers don't quite add up here. The bottom should say 53% rather than 57%, 53.8, I think it is, or 52.8. But the answer is about 50% of people felt they were given the wrong diagnosis before they got the encephalitis diagnosis. This is consistent with the literature. It does vary depending on who you ask and what kind of encephalitis you're talking about. Interestingly, the majority of these apparent misdiagnoses were physical health diagnoses, and they ranged from things like migraine, viral illnesses, Parkinson's disease, and then the psychiatric diagnoses were things like psychotic disorders, were I think the most represented, depression, ADHD, and then 1 or 2 sort of answers like they thought I was just putting it on, which was sort of fairly tragic to see, but there was definitely represented there. We're interested, we asked a lot of questions about current mental health symptoms and the symptoms following the diagnosis of encephalitis. And in terms of the colors here, we're interested in the blues, which are current problems. So light blue is, yes, I have this problem currently, and I had it in the past. Dark blue is, yes, I have it currently, but I didn't have it in the past. And the yellow is, well, yeah, I had it in the past, following the encephalitis diagnosis still. So after the diagnosis, I did have this symptom, but I no longer have it. So you can see sleep problems, about 3/4 of people have had it or currently have sleep problems. Mood problems, over 3/4. Anxiety, much over 3/4. We're nearly talking about the majority here. And of course, they're, you know, about 2/3 who are still suffering from anxiety. Sorry, 3/4 who are still suffering from anxiety problems. Inappropriate or unexpected laughter. This is an area that's been looked at by, I think, Chris Butler's group in Oxford recently, and some interesting results there. We don't see that huge numbers, but inappropriate or unexpected crying, we certainly do. Touching on the sort of psychosis spectrum, hallucinations and paranoia reported by about 1/3 of patients who have had encephalitis. And these are symptoms since they had the encephalitis. And aggression, anger management problems, again, about 1/2. So I think this is a nice kind of idea about the symptomatology. This is looking at depression and the current sort of depression scores. And it's a bit of a funny way of representing it, but you can see there was a visual analog scale where respondents had to drag a sort of slider to how often they're experiencing certain symptoms. So you can see the majority of patients are not experiencing suicidality regularly, but there are a lot who are. There is still a reasonable number. Each dot represents an individual person who are still experiencing high degrees of suicidality. And the same with low mood. In fact, there's a sort of even more sort of equal spread, and the same with anhedonia, or the inability to feel pleasure. And this is getting at the idea that there may be quite a few patients who are experiencing current depression, and we've asked some other questions to get at that diagnosis too. So, yeah, it's called anhedonia, and so it's a core symptom of depression, and so it can exist by itself, or it can exist with a sort of depression diagnosis. It's again.
Good morning.
Oh, I don't know what that was. Maybe we can come back to it in the talks, but it's a core symptom of depression and something that many patients will experience, and that, along with apathy, which is often a little bit difficult to differentiate, can be quite disabling, sometimes even more so for carers and family, actually. So this is a question that we were quite concerned about, and in many ways, this is one of the headline findings, or one of the more disturbing findings for me, is that 38% of patients had thought about killing themselves, and 4.3% had actually tried to kill themselves. And I think in terms of trying to get people to listen to the news about the severity of encephalitis, that's really important. It's actually consistent with a Danish study of the entire population of Denmark, showing that people with this disorder are at an increased risk of these thoughts and behaviors. Any formal mental health diagnoses, you can see there are significant diagnoses of depression, anxiety, but even panic disorder, psychotic disorders, OCD, and PTSD are all represented in proportions which are far in excess of what you would expect in the general population. We haven't done those direct comparisons yet, but we will. And this is interesting. This is when we ask patients about whether they feel that they have mental health or psychiatric diagnoses that have not been diagnosed by a mental health professional. And you can see that the numbers here are fairly big. Hi there. Right. Oh, I'm sorry. So the blue is, yes, I currently have that diagnosis. The green is, yes, I had that diagnosis in the past, but after I was diagnosed with encephalitis. And the dark green is, I had it in the past, but before my encephalitis. Right. So again, this is, in a way, the dark green is showing that encephalitis can hit anyone, including people who already have mental health problems. But this is the list of diagnoses that people think they may have that haven't yet been diagnosed or haven't been diagnosed by a health professional. And I think this is interesting because it goes to show that there's a lot of people who think that they haven't received a correct diagnosis, whether or not they're right about them having that diagnosis. In a way, is neither here nor there, because I think what this shows is that there is a need for assessment of these diagnoses. And we're talking about multiple different domains, not just mood disorders, but anxiety and even psychotic disorders. And in terms of treatment that people have received, the majority have received medication. Some have received cognitive behavioral therapy, a form of talking therapy. Other psychotherapies are represented there, and about a third each have received neuropsychological therapies or occupational therapies. Again, interesting to see how that will break down according to different kinds of encephalitis. And this was a question that was inspired by the last event here that I came to. So afterwards, I spoke to a lot of people and I was just really struck by the number of people who came up to me and said, you know what, I have this real sensory hypersensitivity to noise or to lights. And I hadn't read about this in the context of encephalitis. And it was something that I really wanted to include. So we did include some questions on this. And sure enough, sensory hypersensitivities were reported by a very large number of respondents to sound in 60%, almost the same to light, but even things like temperature, smell, taste, touch. And this is something that I think it would be really nice to dive into in later work. Probably some similar results coming from the traumatic brain injury literature and some other neurological disorders. Okay, so that's all we've got time for, but just to conclude, people who've had encephalitis may experience a range of mental health problems, as we've seen. And although some feel that they have received appropriate input, I think many feel that they either haven't received an appropriate diagnosis or received appropriate care for those problems. My message is, don't suffer in silence. What this means is really, if you are experiencing difficulties, do talk to your GP or to your neurologist, or if you're lucky enough, to your mental health team. But from the health professional side, I think we can do better. I think we need to ask specifically about mental health symptoms in every patient that we see, and we should include these sort of symptoms that we're just thinking about now. Sophie Binks has done a lot of work on fatigue, for example, which never gets asked about, and which we find that if you do, you really hear a lot about. Hypersensitivity is like this inappropriate laughter and crying. I think we're expanding what we understand to be these consequences of encephalitis. And in terms of service development, this just needs to take into account the likely ongoing needs of people who've had encephalitis, as is already the case for many brain disorders. I think we have reasonable systems set up for some disorders like Parkinson's, like MS, for example. We need parity here. And so for encephalitis, I hope in the years to come, we can see that. So I just want to thank all my colleagues who work on encephalitis, both in terms of clinical work and in research, but also for everyone who's on the neuropsychiatry MSc at King's College London, because these are the future clinicians who are going to be dealing with encephalitis. And we teach on encephalitis, Ava comes to teach on it, and we think this is really important in kind of spreading awareness of these kinds of issues. So thank you.